Welcome to the deep dive. We're tackling a really challenging area today, chronic non-healing wounds of the extremities.
Yeah, a tough one.
Our source material is packed, specifically the wound care chapters from Rutherford's Vascular Surgery, 10th edition. We're going way beyond just surface treatments here.
Right, trying to understand what's really happening underneath.
This is such a critical issue, and its importance is, well, it's growing right along with diabetes and obesity rates.
Absolutely. Those conditions, unfortunately, significantly bump up the likelihood of developing these stubborn wounds.
Yeah, they really do. And when these wounds resist the usual care, it's often the vascular surgeons who get called in, right, as the experts.
That's often the case.
It's easy to think, the solution is just the latest cream or dressing, but what we're really diving into is this core idea. The absolute key is finding and treating the root cause.
Precisely. And the stakes are really high. For people dealing with poor blood flow, arterial insufficiency, or diabetic nerve damage.
The risk is significant.
Yeah, the risk of limb loss is alarmingly real.
Yeah.
It just highlights why getting that diagnosis right and targeting the treatment is so incredibly vital.
Which brings us to these specialized wound clinics. We hear more and more about them.
They definitely play an increasing role.
They promise better outcomes, and it makes sense, doesn't it, given the complexity? It's about teamwork.
It is. Bringing together a multidisciplinary team and having vascular specialists involved, well, that's clearly crucial for the vascular side of things.
Which can often be the main driver.
Exactly. The real strength is coordinating all those specialists, maybe endocrinologists for diabetes, podiatrists, orthotists for offloading the foot.
Physical therapists, too.
Physical therapists, yes, and us, the vascular surgeons.
Yeah.
That kind of collaborative approach gives patients the best chance.
Okay, let's get down to basics then. What does it look like when a wound does heal normally? What's that process?
Right. Normal acute wound healing, it's actually quite elegant, a really organized process. It unfolds in 4 stages, but they overlap.
4 stages.
Yeah. First, hemostasis, stopping the bleeding, then inflammation. After that, proliferation, and finally remodeling. But like I said, they flow into each other. It's a continuum.
Okay, so stage 1, inflammation. What's the body doing right after you get cut, for instance?
So the inflammatory phase kicks off pretty quick. Within the first 24 hours, it can last, about 2 weeks.
And who are the main players?
You've got mast cells, neutrophils, and macrophages playing key roles. They release a whole cocktail of signaling molecules.
Like what?
Things like chemokines, various cytokines, TNF-alpha, IFN-delta, interleukins, and different growth factors too.
And what are these signals actually doing in the wound?
They're basically marshaling the troops. Directing the initial response, calling more immune cells in, activating fibroblasts and epithelial cells, they're repair workers.
Okay.
And importantly, neutrophils arrive and start releasing matrix metalloproteinases, MMPs.
And MPs? Heard of those.
Think of them as tiny demolition crews. They start breaking down damaged tissue, old collagen, gelatin, elastin, clearing the debris.
So early on, MMPs are actually helpful. Seems counterintuitive sometimes.
Yes, in a controlled way. That's the key. Their activity is tightly regulated by TIMPs, tissue inhibitors of metalloproteinase.
Ah, the checks and balances.
Exactly, mainly produced by macrophages. This balance between the MMPs breaking stuff down and the TIMPs controlling them is absolutely critical. Cleans up effectively without causing too much collateral damage.
Got it. So initial cleanup done. Then we move into the proliferative phase. What's the goal here?
Proliferation is all about rebuilding. Growth factors are key drivers here. PDGF, TGF-beta, VEGF, mostly coming from those macrophages we mentioned.
And VEGF is for blood vessels, right?
Right. VEGF is crucial for angiogenesis, making new blood vessels. The wound needs a fresh supply line, for nutrients and oxygen. Angiogenesis builds those tiny new supply roads.
So who are the actual builders on this construction site?
That's where fibroblasts come in. They migrate into the wound matrix, responding to those growth factor signals.
And
they start making collagen and proteoglycans. These materials form granulation tissue.
That pinkish stuff you see in a healing wound.
Exactly, that bumpy pink tissue. It's the scaffold for the new skin.
Sounds like a very carefully choreographed dance.
It really is. The growth of these new capillaries, it has to be orderly. Needs a complex mix of different VEGF types, TGF-beta, and another molecule called HIF-1.
Hypoxia-inducible factor.
That's the one. And just like before, MMPs are still needed. Those budding capillaries secrete them to help tunnel through the tissue and create those new channels.
All right, so we've cleared the damage, rebuilt the foundation with granulation tissue and new blood vessels. What are the final steps?
Final stages are epithelialization and remodeling. Epithelialization is basically resurfacing the wound with new skin cells.
Getting the roof on.
Kinda, yeah. It happens fastest on a nice, healthy bed of that granulation tissue, driven by growth factors like EGF and KGF.
And the cells just migrate across.
They migrate from the wound edges, and again, they use MMPs to dissolve any last bits of non-viable tissue in their path. They keep going until they meet in the middle and close the gap.
And remodeling. That sounds like the finishing touches.
Exactly. Remodeling takes time. It can go on for months. The initial collagen laid down, type 3, it's a bit weaker.
Less organized.
Less organized, yeah. It gets gradually replaced by the stronger, more mature type II collagen. And guess what's needed for that?
Let me guess. MMPs and TIMPs.
You got it. Still need that balance. MMPs to break down the type 3, TIMPs to control it. Ensures the new tissue is strong, durable, the scar matures over time.
Okay, so that's the ideal scenario, but we're here because things often go wrong. What breaks down in this process to cause abnormal healing, these chronic wounds?
Chronic wounds happen when this normal, orderly process gets disrupted. Very often it gets stuck in a prolonged inflammatory state.
Stuck in phase 1 almost.
In a way, yeah. There are several common underlying issues. Persistent venous hypertension, chronic pressure like from lying in one position.
Bed sores, yeah.
Bacterial colonization, not enough blood flow tissue perfusion, and even something called cellular senescence.
Cell aging.
Essentially, yes.
Yeah.
The cells in the wound area just get old and don't function properly.
Let's dig into that inflammation part more. You said it's crucial early on, but how does it become a problem in chronic wounds?
That's the paradox. In chronic wounds, you get this persistent, often excessive activation of pro-inflammatory cytokines and MMPs.
The stuff that was helpful initially?
Exactly. But when it goes on too long, it becomes counterproductive. The fluid in these chronic wounds, it can actually stop normal fibroblasts and keratinocytes from working properly.
The repair cells?
The very cells needed to rebuild tissue and close the wound. It's like the body's alarm system gets stuck on and starts causing more harm than good.
So the cleanup crew never leaves and just keeps wrecking things.
That's a decent analogy. This chronic wound fluid often has really high levels of destructive MMPs, like MMP2 and MMP9.
But not enough of the controllers.
Right. Surprisingly low levels of their inhibitors, the TIMPs. This imbalance just leads to ongoing breakdown. Interestingly, with venous ulcers, putting on compression therapy actually helps reduce these high MMP levels.
Ah, so that's one mechanism for how compression works.
It's likely one important part, yes.
And what about those growth factors? VEGF for blood vessels, you said it was vital. What happens there?
Another paradox. Studies show VEGF levels can actually be quite high in some chronic wounds, like venous ulcers, sometimes even higher than in acute wounds.
But they're not working.
Doesn't seem to be effective. Maybe something's inhibiting it, or the cells just aren't responding anymore, lost the receptors perhaps. But then on the flip side, patients with severe arterial blockages, critical limb ischemia.
T-cell.
Right. They often have the opposite issue, lower VEGF levels down in the limb, which definitely contributes to poor healing.
You mentioned cytokines too. How do they keep wounds chronic?
We see higher levels of pro-inflammatory ones like TNF-alpha, IL-1, IL-6, and chronic venous wound fluid. The good news is, as these ulcers start healing, those levels tend to drop.
And in diabetic ulcers?
Similar picture, often that pro-inflammatory upregulation, but sometimes it's coupled with less production of those key angiogenic factors for new blood vessels. It's complex.
And this idea of cell senescence, aging cells, how does that play in?
Yeah, research shows fibroblasts taken from chronic ulcers can act, well, old, senescent. They don't multiply well, don't respond strongly to growth factor signals like TGF-beta1, especially in advanced venous disease.
They just get sluggish.
Sluggish is a good word. They look different, grow slowly. So finding ways to stimulate these tired cells, that's become a potential therapeutic target, like trying to jumpstart an old engine.
Wow. It's a really complex mix of things going wrong at the cellular level. Have treatments targeting these specific mechanisms been successful?
That's the tricky part. Because it is so complex, developing effective therapies targeting these mechanisms has been, well, difficult.
Like trying to target MMPs.
Exactly. Early attempts to just broadly modulate MMP activity haven't really panned out. There was a special dressing designed to bind MMPs in the lab.
Sounds promising.
It did, but in a big clinical trial on diabetic foot ulcers, it didn't show a significant improvement compared to just simple saline gauze.
So just blocking MMPs isn't the answer?
Apparently not. As we said, MMPs do have essential jobs in normal healing capillary growth cell migration.
Blocking them completely could actually hinder things.
Right,
Even anti-inflammatory drugs, you'd think they'd help
right.
calm things down.
Seems logical.
But the evidence isn't strong enough to recommend using them routinely for venous leg ulcers.
That is surprising.
It really highlights how critical the timing of inflammation is. Some studies even found that untreated venous ulcers that started with higher levels of certain pro-inflammatory cytokines actually healed better with just compression therapy.
Huh. So maybe that initial inflammatory burst is needed to kickstart things properly.
It suggests we need more sophisticated strategies, maybe timed interventions. A big hurdle is we lack quick, easy tests, point-of-care tests, to measure MMP and cytokine levels right there at the bedside. That makes targeted treatment really hard.
Okay, so understanding the why is incredibly complex. Let's switch gears. How do we figure out the what? What are the main underlying causes that lead to these ulcers?
Getting the diagnosis right, finding that underlying cause, is absolutely the most critical first step. You can't treat effectively otherwise.
And it's not always just one thing.
No. Keep in mind, in over 20% of leg ulcers, there can be multiple causes contributing, so you need a really thorough evaluation.
Let's start with venous leg ulcers. They seem quite common.
They are. They're linked to the usual risk factors for venous disease family history, jobs with prolonged standing, history of DVT.
Okay.
The key is that problems anywhere in the venous system, superficial veins, deep veins, the perforators connecting them, or any combination can lead to ulceration.
And how does that high vein pressure actually cause the skin to break down?
The exact pathway is still debated, honestly. But basically, chronic venous hypertension leads to persistent leg swelling, edema,
Right.
and triggers this pro-inflammatory cascade. Over time, this causes the skin and underlying tissue to thicken and harden. That's called lipodermatosclerosis.
Like a pre-ulcer state.
Exactly. It's a warning sign.
Okay.
If you don't manage the venous issues or the swelling aggressively then, an ulcer can pop up, sometimes spontaneously, sometimes after just minor trauma.
Makes sense. What about diabetic foot ulcers? A huge problem.
Huge. Usually it's a combination of neuropathy, nerve damage, plus vascular insufficiency, poor blood flow, and often infection thrown in.
A triple threat.
Pretty much. And it's absolutely critical to grasp at this. While dressings matter, the most important thing is pressure offloading.
Getting the weight off the wound.
Completely.
Yeah.
No fancy dressing can heal an ulcer on the bottom of the foot if it's constantly being pressed on. Expert orthotists, good patient education on using the offloading devices, that's far more impactful than the specific dressing choice.
Crucial point. Okay, and then ulcers from poor arterial blood flow. Arterial insufficiency ulcers.
Right. The main goal there is keep them clean, infection-free, stable, until you can restore blood flow with revascularization.
So manage locally until the plumbing's fixed?
Essentially, for open wounds, maybe moisture-retentive dressings, sometimes antimicrobial if you're worried about infection. If it's dry, black Escher, that hard dead tissue,
Yeah.
then you actually want to keep it dry. Maybe use some alcohol or iodine, cover it with gauze,
Mm-hmm.
protect it. But the absolute first step for any leg ulcer is checking the arterial supply.
Got it. You mentioned less common causes, too.
Yeah, things like vasculitis, blood vessel inflammations, sickle cell anemia, sometimes cancers, various skin diseases.
Hmm.
They can all cause ulcers.
So if an ulcer looks weird or isn't healing...
You biopsy it, definitely. Especially to rule out something called a marginal ulcer.
What's that?
It's a type of skin cancer, squamous cell, that can develop in a long-standing, previously benign chronic wound. If a wound just stops healing or changes character, you have to think about it.
Okay, good to know. So with all these potential causes, how do clinicians figure out what's actually going on, the initial workup?
Often, a good history and a careful physical exam get you most of the way there. Key things to note about the wound itself are its depth, any signs of infection, and any signs of ischemia, poor blood flow.
And are there standard ways to classify them to help guide treatment and predict outcomes?
Oh, yes. Several systems exist. Megat Wagner was an early one for diabetic feet, focused on depth, infection, gangrene, but a bit limited.
Okay.
The University of Texas system improved on it, specifically adding depth, infection, yes, no, and ischemia, yes, no, for each grade. Better predictor.
And what's used most commonly now?
The WIFI classification, WIFI, stands for wound, ischemia, and foot infection. It's widely used, validated for predicting amputation risk.
There's a more detailed picture.
Much more granular assessment of wound severity, the degree of ischemia based on tests, and the extent of infection. Some people add ambulatory function too, how well the patient walks.
Makes sense. Once you've classified it, how do you track progress?
Regular, accurate wound measurement at every visit, absolutely crucial. Tracks healing or lack thereof.
How was that done? Ruler?
Can be simple length and width.
or planimetry tracing the edges. There's also software now that uses digital photos. You need to see if it's getting smaller or if maybe inflammation or colonization is creeping back in.
You mentioned wound bed preparation earlier. What exactly does that involve?
Right, wound bed preparation. It's a systematic approach to tackling local factors in the wound that stop healing.
Like what?
Key things are debridement, removing non-viable tissue, identifying and correcting bacterial issues, controlling chronic inflammation, getting rid of edema or swelling, and managing exudate, the wound drainage.
Okay, let's focus on the first couple there. Debridement and bacteria. Debridement removing dead tissue, right? Why is that so vital?
That's it. Most chronic ulcers have non-viable stuff. Callus, Escher, fibrin, slough. It's dead, it harbors bacteria, and it physically blocks healthy cells from migrating across to close the wound.
So you have to get rid of it.
Absolutely. Aggressive debridement, especially early on, is essential. There's even some thought that the tissue around old diabetic and venous ulcers might be senescent.
The aging cell thing again.
Yeah, suggesting maybe even excising some of that surrounding tissue could help create a healthier, more acute wound environment.
So more debridement equals better healing.
Ah.
Is there evidence for that?
Several studies point that way. An analysis of a diabetic foot ulcer trial found centers doing more frequent debridement had better healing. A retrospective review correlated frequent debridement with higher closure rates.
And weekly debridement.
Another large study found weekly debridement led to faster healing across various chronic wounds. So while we don't know the perfect frequency or timing yet, its importance is clear.
Are there alternatives to sharp surgical debridement? Sounds potentially painful.
There are. Chemical debridement, ultrasound, hydrodebridement using water jets, even larval therapy maggots.
Maggots, really?
Yep, medical maggots. These alternatives can be useful when surgical debridement is difficult, like in long-term care settings.
Tell me about chemical debridement first.
Usually enzyme-based, like collagenase, can be okay for breaking down moderate amounts of soft, fibrinous slough.
But not the tough stuff.
Generally not great against thick Escher or hard callus.
And the larval therapy? Maggots in the wound?
Correct. Some studies, mostly non-randomized, showed they achieved complete debridement more often than, say, autolytic or chemical methods in pressure ulcers.
But randomized trials?
One compared larvae to hydrogel in chronic leg ulcers. Larvae debrided faster, yes, but patients reported more pain. And importantly, there was no difference in overall healing rates or quality of life.
What about ultrasound?
Investigated as maybe less painful. Contact ultrasound uses fluid to deliver energy, helps loosen non-viable tissue. But non-contact mist ultrasound hasn't really shown significant debridement effects.
So bottom line on debridement methods.
Surgical debridement is still generally seen as superior, most effective, and often more cost-effective overall. The alternatives are good options when surgery isn't possible or maybe not preferred by the patient.
Okay. Now, bacterial colonization. You flag that as key in wound bed prep. Is infection always the problem when a wound won't heal?
Well, significant infection is common. In diabetic foot ulcer trials, maybe 20–25% needed systemic antibiotics. But the role of bacteria in wounds that don't look obviously infected, that's more debated.
Because even healing wounds have bacteria.
Exactly. Normal healing wounds are colonized. So routine culturing isn't usually recommended if there are no signs of infection. But we are seeing more antibiotic-resistant organisms in non-healing chronic ulcers, which is a concern.
And biofilms, we hear about those a lot.
Biofilms are a major headache. These are communities of bacteria hiding in this protective slime layer they make.
Harder to kill.
Much harder. Resistant to host defenses, antibiotics. They just sit there in chronic wounds, fueling chronic inflammation, inactivating growth factors, stopping angiogenesis, big barrier to healing, and potentially a source of systemic infection if left unchecked.
So how do you know if bacteria or biofilms are the main issue?
It depends on the bacterial load, how many there are the specific species, how virulent they are, and if they've formed a biofilm. There's a general threshold, around 104, maybe 105 CFU per gram of tissue.
Above that, healing slows down.
Tends to decrease, yeah.
And how do you measure that load?
Gold standard is a quantitative tissue biopsy, but it's often just not practical routinely.
What about swabs? Everyone uses swabs.
They do. Semi-quantitative swabs are common because they're easy, but a recent study actually found they're pretty unreliable. Don't accurately reflect the true load in the tissue itself.
That's a problem. Any new tech helping here?
Yes, actually. Point-of-care fluorescence imaging is emerging. It's non-invasive, uses violet light.
And it shows bacteria.
It can visualize bacteria in real time if the load is above that 104 threshold. Different bacteria glow, different colors red for porphyrin producers, cyan for Pseudomonas.
So you can see hot spots.
Exactly. Clinical trials show high accuracy, much better sensitivity than just looking at the wound. Could be a real game changer for guiding debridement and antimicrobial use.
Sounds very useful. Okay, let's talk dressings. So many types. How do you choose?
Selection should really depend on the wound itself. Location, inflammation level, how much it's draining, the exudate.
Moisture balance is key, right?
Absolutely critical. You need moisture for cells to grow and migrate. But in chronic wounds, that exudate is often loaded with inflammatory cytokines, proteases.
The destructive stuff.
Right. So you need to wick away excessive fluid to stop it damaging the surrounding skin. That's crucial too.
What about all those dressings with added extras? Collagen, zinc, honey. Do they work better?
Lots of things get added with the idea of boosting healing. But honestly, high-quality evidence showing significant clinical benefit from most of these additives is pretty thin.
So it's more about the basic material properties.
Largely, yes. Let's quickly run through common types. Alginates from seaweed, great for absorbing moderate to heavy exudate, form a gel, need a cover dressing. Collagens provide a scaffold, encourage progression. Again, usually need a secondary dressing, generally not for infected wounds. Composites combine functions, maybe antimicrobial, absorption, adhesion.
Foams.
Foams absorb moderate exudate, good under compression. Gauze, traditional stuff, permeable. Mostly for cleaning or as a secondary dressing, not ideal as the main contact layer.
Hydrocolloids.
Hydrocolloids form a gel, facilitate autolytic debridement, but they're occlusive, trap bacteria, so not for infected wounds. Hydrogel's high water content donate moisture to dry wounds, help autolysis, can soothe pain. Need a cover.
Super absorbents.
For really heavy drainage, lock fluid away to prevent leakage and maceration.
So different wounds need very different approaches.
Totally. Diabetic foot ulcers, often low exudates, so maybe need moisture-donating hydrogels. Heavily draining wounds, alginates, hydrofibers, venous ulcers, high exudate, lots of proteases, need absorbent, wicking dressings under compression, changed often.
What about antimicrobial dressings? Seems logical if bacteria are a concern.
It's a balance. They can reduce bacterial load, yes, but might also slow down healthy tissue growth. Long-term iodine use fell out of favor due to lab studies showing fibroblast suppression.
Cadexamer iodine.
Slow-release versions were developed. One small study showed faster healing in venous ulcers with compression compared to wet to dry.
And silver. Very common.
Very common. But a big Cochrane analysis found insufficient evidence to strongly recommend them for infected or contaminated wounds. One study showed faster early closure in critically colonized venous ulcers with silver foam under compression, but didn't track to full healing. Another big trial found no benefit from routine silver use over 12 weeks with high compression in venous ulcers.
So routine silver isn't necessarily better and costs more.
That was the conclusion. So the thinking now is don't use topical antimicrobials routinely long-term, but targeted use in truly critically infected wounds might be beneficial.
Okay, let's shift back to specific ulcer types. Venous leg ulcers again. Beyond dressings and compression, what else?
If patients are candidates, they need diagnostic studies, find out the venous anatomy, physiology, look for correctable issues, saphenous reflux, incompetent perforators, iliac vein blockages. There are detailed guidelines on this from the AVF and SVS.
And compression remains king.
Absolutely.
Yeah.
Sustained, high-strength suppression. It's the foundation. Start it early, keep it going throughout treatment. Nothing else works well without it.
Any medications that help venous ulcer healing?
A few show some promise alongside compression. Pentoxifylline improves blood flow reviews, show it improves healing rates combined with compression. One study showed healing around 71 days versus 100 with placebo.
Okay.
Flavonoids, plant compounds. A couple of trials showed significant benefit with compression. And interestingly, one trial found daily low molecular weight heparin for a year, sped up healing significantly in patients also getting compression and surgery.
Heparin, like a blood thinner.
Yeah, but the cost and complications probably limit that to really tough recalcitrant ulcers.
What about procedures to fix the veins themselves? When is that done?
Well, a key trial compared saphenous vein stripping plus compression versus just compression. The surgery group had significantly fewer recurrences years later.
So fixing the superficial reflux helps prevent them coming back.
Exactly. So it's reasonable for reducing recurrence if superficial reflux is significant, which is maybe 30–50% of cases, but generally not done just to speed up initial healing.
And fixing perforators or varicose veins in the ulcer?
More controversial.
Yeah.
Limited evidence for routinely doing that. Deep vein reconstruction is a whole other complex area for select cases.
So compression is the main thing for healing. What about other add-ons?
Compression alone heals maybe 60–70% in 4–6 months. Lots of other things have been tried, skin grafts, growth factors, but often lack strong supporting data. Physical therapy, though resistance exercises, walking might offer some extra benefit with compression.
Skin grafting seems logical for a big hole.
It's been done forever, but surprisingly, high-quality evidence is limited for venous ulcers. A Cochrane review calls for more research. Some docs consider it for slow wounds or big defects if the bed looks good.
But graft take isn't guaranteed.
Not always 100% no.
Yeah.
For huge ulcers with lots of skin hardening, sometimes radical excision and free flaps are considered, but that's major surgery. And there are tons of cellular and tissue-based products now, but long-term data is still evolving.
Okay. Turning to diabetic foot ulcers, we hit offloading hard. Any other adjuncts?
Vitamin D supplementation is interesting. One randomized trial showed significantly better wound size reduction and metabolic improvements in severe DFUs with standard care plus vitamin D every 2 weeks.
So check vitamin D levels.
Many clinicians think supplementation is reasonable, especially if levels are low.
And growth factors. Only Bicaplermin.
Yes, PDGF Bicaplermin is the only FDA-approved one for DFUs. It's a topical gel, daily application with saline gauze.
Does it work well?
Meta-analyses show a modest improvement in healing rates, maybe 50% healed versus 36% with placebo at 20 weeks. Adverse events are rare.
But there was that black box warning.
There was, back in 2008, about a potential increased cancer death risk. Later studies haven't really confirmed increased risk of getting cancer, but maybe a higher death risk if you got cancer while using it. So, used cautiously, usually for ulcers not responding to standard care, it also adds cost.
Got it. Finally, arterial insufficiency ulcers. Revascularization is key if possible. What about local care and other options?
First, you need diagnostics, ABIs, toe pressures, TCPO2, laser Doppler to predict healing chances without fixing the blood flow.
And local care.
Keep it clean, stable until revascularization. Moisture retentive for open wounds, maybe antimicrobial. Dry Escher. Keep it dry, alcohol iodine, gauze padding.
And deciding on revascularization.
Based on rest pain, wound severity, test results. Balance healing potential versus procedural risks. Some patients who aren't surgical candidates can manage with wound care, but consider revascularization early for rest pain, bad wounds, gangrene.
And if they don't get revascularized?
Monitor closely. If no progress in 4–6 weeks, maybe reconsider intervention. And remember, poor arterial flow can complicate any ulcer, so always check the supply.
Any meds help arterial ulcers heal? Pentoxifylline? Cilostazol?
No high-quality evidence they accelerate healing in arterial ulcers specifically. Prostaglandins, maybe some benefit in CLI studies, but they need IV infusion, have side effects not FDA approved for this.
What about angiogenesis therapies, growing new blood vessels?
Lots of excitement initially about VEGF, but translating to humans has been tough worries about tumor growth. Gene transfer had potential.
But nothing approved.
No angiogenic growth factors are FDA approved for CLI or leg ulcers. Larger trials just didn't confirm early promise. Same story really for progenitor cell therapies. So far, no clear reduction in amputation or improved healing yet, though trials continue.
Disappointing. What about intermittent pneumatic compression, IPC? Squeezing the legs.
IPC has been shown to increase blood flow in ischemic limbs, so there's potential. Different types exist, synchronized with heartbeat or non-synchronized.
Non-synchronized is simpler for home use.
Generally, yeah, cheaper too. Mechanisms. Maybe reduces edema, increases pressure gradient, boosts vasodilators like nitric oxide.
Any evidence it helps ulcers.
Studies show increased popliteal flow, even with arterial disease. Claudication studies showed improved walking distance. For actual ulcers in non-revascularization patients, some studies using synchronized IPC showed good healing rates, especially with better baseline oxygen levels.
And non-synchronized.
Case series report limb salvage and healing, though maybe not as good in kidney failure patients. One retrospective study suggested lower amputation rates with IPC if revascularization wasn't an option. It's encouraging. We still lack big prospective randomized trials specifically for ulcer healing with IPC.
And after successful revascularization, what's key for wound care then?
Critical period. The local environment changes. Limb edema is common after bypass, can actually worsen wounds if not managed.
So compression right away.
Short stretch compression can be very helpful. Need an edema control plan for discharge elevation, ongoing compression. IPC devices can also limit early post-op swelling.
And watching dry gangrene areas.
Crucial. As healing starts underneath after blood flow is restored, infection risk goes up. Needs close monitoring, ongoing debridement, careful management.
Okay, we've covered a ton on local care and meds. What about biophysical tech? Negative pressure, oxygen?
Negative pressure wound therapy, MPWT. Vacuum-assisted closure applies suction. Removes exudate, stimulates cells, promotes angiogenesis. Often used for complex wounds, exposed bone or tendon.
Does it work?
Lots of reports, but systematic study took time. A key 2005 RCT for diabetic foot amputations showed higher healing rates with NPWT versus standard moist care. Another big RCT on non-ischemic DFUs also showed better healing and fewer secondary amputations with NPWT.
So it's standard now.
It's a fixture in many places, very useful for complex wounds, but needs careful use, specific goal, not just slapped on everything.
And oxygen therapy, hyperbaric.
Hyperbaric oxygen, HBO, breathing 100% oxygen under pressure. Aims to boost tissue oxygen delivery, reduce inflammation edema, inhibit infection. Reported for complex DFUs, osteomyelitis, necrotizing fasciitis, helping flaps heal. Usually 20-40 daily sessions. Proposed mechanisms. Stimulates angiogenesis, enhances cell function, normalizes microcirculation,
Downsides.
can improve TCPO2 levels. Generally safe, but rare serious side effects possible. Coverage can be an issue, specific indications needed after standard care fails.
Does it improve outcomes?
Evidence is mixed. One RCT showed lower amputation rates in ischemic DFUs. A double-blind study showed better closure in non-ischemic DFUs. But a Cochrane review found benefit, but based on small studies, called for more research.
Predictors for who benefits?
Some studies use TCPO2 response. If it goes up during a trial session, maybe better healing. But another big DFU study found no significant difference in healing or amputation with or without HBO. Cost is also high.
So still debated.
Somewhat, yes. Though some assessments suggest it might be cost-effective for DFUs in certain situations.
And topical oxygen, applying it directly.
Yeah, that's seen some encouraging recent trials for DFUs. Seems to supplement local oxygen, maybe increases collagen, decreases infection, promotes angiogenesis and VEGF. It's still relatively new, but promising.
Well, this has truly been a deep dive into a really complex area, chronic non-healing wounds.
Wow.
It's so clear it's way more than just putting on a bandage.
Absolutely. Effective management. It needs that deep understanding of the why, meticulous local care, and integrating all these different therapies, medical, surgical, biophysical.
It's still evolving.
Constantly.
Yeah.
Our understanding of the basic mechanisms keeps growing, and research into new adjuncts offers real hope for patients suffering with these really debilitating conditions.
So as we wrap up, here's a final thought for you, our listener. Considering this incredible web of factors from cellular signals right up to advanced technologies, what single aspect of chronic wound care do you think holds the most promise for the next big breakthrough? Where might we see the most significant advance in helping these persistent wounds finally heal? Thanks for joining us on the Deep Dive.